All right. So we are going to talk about a couple of subpopulations within the greater kind of umbrella of eating disorders. I don't know if specialty is the right word, but I think it's just important that we recognize some of the areas that we haven't done as well at recognizing, and as we gain knowledge for these different populations that also struggle with eating disorders, that we give it a little bit more attention and time. So again, everything's a specialty and everyone that struggles is important, but these are some of the areas that for a long time we didn't know much, or we continue to not know as much as we need to. So we just want to touch on them a little bit uniquely. So I am going to get started with talking about adolescence. And as we have mentioned with adults, anybody who struggles with some sort of trauma, and in particular, someone who is young, who is impressionable, who doesn't have a greater understanding of how things work in the world and how things work in relationships, if they grow up in an environment that involves any type of significant instability, it can lead to a greater likelihood for acquiring eating disorder behaviors. One study done over a decade ago identified that bullying, teasing, competition, and conflict, particularly as it relates to the body and how the body functions in that, teaches males in particular to shun dependence. They have less emotional support, and it complicates their overall emotional intimacy. Bullying in general is directly correlated with increased risk of eating disorder behaviors in childhood. Also, ability to function and participate in exercise and different sports events is really important for a lot of adolescents growing up. It teaches you a lot of different dynamics, working with different types of people, functioning in a space where you're maybe not the center of attention and you have to figure out how to deal with different conflicts. So if you have negative experiences associated with those types of environments, that can be a trigger. In addition, if you lack participation in some of those different environments, that also could be a trigger, especially if you feel if it's lacking because you don't make teams, or you feel left out, or you're not included. And I'm not talking about this happening once or twice. You know, we all build up age-appropriate resistance that one of the webinars, or one of the podcasts took a look at that resilience that we build up, but it has to be age-appropriate resilience. And so having some sort of failures and not making the team, I can relate to so many of those types of moments, but I also had a lot of success. So it is important to recognize that it's not just disappointment in general. It's usually a little bit greater than that. Divorce for some could be a significant trauma, and for others, it's not. Sexual abuse, physical abuse, verbal abuse, any type of learning disability, or recognition that you aren't a part of the norm, or you aren't keeping up with the norm, can be significant. And then being in an environment or around people that are constantly talking about weight or their diets. Oftentimes we make joking, self-deprecating statements about our body. That's pretty normalized for us to jab at ourselves, and people kind of laugh at it with us. And so that's something that gets picked up very quickly. And in particular, any stronger disordered or eating disordered behaviors that are identified, that nature versus nurture. So when we take a look at how we support nutrition interventions and create some different goals for adolescents, it's obviously a lot trickier because they're growing and everyone has a different kind of path for what that growth is going to look like. So we want to make sure that we are not using straight BMI calculations for goal setting for adolescents. BMI already has its issues, but on top of that, it's just not an effective measurement or tool for adolescents. So instead, what I have always used, and what is oftentimes used, is the BMI for height and gender growth chart. So it is looking at BMI values appropriate for adolescents, and it's taking into consideration gender and also height. So and also considerations for age. So it's got all the components included, which gives a little bit more of a wide range than if we're just looking at height for age or any of that. So it's a little bit more well-rounded. Now, when we take a look at percentiles, understanding that similar to the qualifications and classifications of categorizations of weight that come with BMI, we have the same thing that happens with percentiles, with 5th percent and below being considered underweight or at risk, 85th percent considered to be overweight, 95th percentile is where the categorization of obese is, and they start looking at that. So it's important that you also kind of create a normalized range. You wouldn't necessarily want to look at the 0 percentile through the 100th percentile when creating some sort of parameters for weight restoration or re-nourishing or catching up on that growth curve. So a lot of times I've used the 25th to 85th. It gives a nice large range, similar to using BMI of 20 to 24, which allows people greater opportunity to fit within that range. And when I'm working with insurance companies that are always quick to eliminate care at lower weights, it gives me a greater opportunity to get them to a more stable place. So this link here helps you to kind of do some of that determination. You can just plug in the values and it'll help you get the weights associated with those percentiles. We remain with the regular eating. Kids snack pretty frequently anyway, so that 3 meals, 3 snacks, all foods fit. And there does need to be some considerations for food allergies. Children have a greater incidence of food allergies, although it's still pretty significantly small for the overall population. The 8 most common food allergies being listed below. And it is important to recognize it's about 8% of children who have food allergies, which relates to about 6 million in total. But a lot of times food allergies are outgrown as they move into their adolescence, teen, young adult years. Not everyone, but a lot can actually outgrow that. What?
Can we do the...
No. So I'm going to share a little bit here. This is my firstborn, Elliot, eating some cut up green beans and bananas, not looking super thrilled. And I had this perception that because I knew everything that I knew, and I had been working in eating disorder care for a number of years before I got pregnant with him, I was going to have the greatest eater and that I was going to expose him to all these foods and he was going to love everything. And I really didn't get to have much say in that. So the difficulties that can be associated with helping a child understand food and garnering a positive relationship and an appropriate and functional relationship around food is difficult just in and of itself. But if somebody is already struggling with foods themselves, it can make it even more challenging. So this comes again from Ellen Sater. I actually have Secrets to Feeding a Healthy Family right here. I mean, her resources and references, this is just one of her books, are amazing. So some things to consider when working with families, and this can come from 2 perspectives. You're working with a family that has a child that's maybe already struggling with some issues, or you're working with a parent who has children that is recognizing some behaviors in their children associated with how they've engaged in their eating disorder behaviors. So these are just great tools and tips for all of that. So eating meals together can be really important. It helps to reduce the chaos of mealtime. It creates some structure, and it lets the kids stop eating when they are done. In other words, they have a sense of understanding that this mealtime is secluded, and when we sit down, we eat, and when we're done, we leave. It's important to not make different or special meals for your kids and to get them in the regular routine of eating what everybody eats. It's not to say that if you can't do that, it won't work, but it's just helpful to have that consistency and that exposure, and watching people eat foods can help them create kind of a mimicked behavior, even if they maybe don't particularly enjoy it all the time. Avoid using food as a reward or a punishment. I know this can be really hard, and it's not to say that you should never do it. The idea behind this is, as I listed here, it doesn't include celebratory meals or desserts, but it does include using food as an incentive. For instance, no dessert if you don't finish dinner. I get it from a logistical standpoint. You want them to get the nutrients from the food. You want them to be full. But if if attaining a sweet food or a food that's really enjoyable, which oftentimes it is, is always coming with some sort of a caveat, then it doesn't truly allow them to connect to true hunger and fullness, especially, if it's attached to like eat everything on your plate. So you just want to be really careful when you use food as too much of an incentivization. Encourage them to help with cooking. You can buy kids friendly knives. You can just get them up there and get their hands dirty. My kids played in the sink with measuring cups for hours while I would bake and cook things. Buy foods that they ask for within reason. Heck, if my kids don't always want gushers in the house, but I don't keep them in the house every single day, but usually they're going to have access to gushers or a fruit roll up here or there. And so those are just easy things that I can bring into the house that bring them a lot of joy for, not that hard. From my perspective, it's not that hard to do. Let them make a mess within reason. Let them play with food. Kids oftentimes get to a point where they're throwing food on the floor just for their own entertainment, and obviously that becomes an annoyance, but there's a certain amount of letting them play with different textures and put it in their mouth, and it doesn't even have to be related to eating time, but again, just that cooking component. And have them keep trying foods even if they aren't enjoying eating them. So something, particularly like vegetables, those types of things. Just because they've refused broccoli a few times doesn't mean you stop putting broccoli in front of them. So all of that different exposure can be really helpful. The trick is that you don't force them to consume tons of broccoli. Ellen Sater has created her division of responsibility, which is something that was posted on Yellow Dig for you all to see. And this is where there are different responsibilities between the parent and the child. So the parent has specific guidelines and the child also has some control. And it is important to allow them to start creating their own decision-making and their autonomy. But they have to be able to do it within some sort of structure that's also appropriate. I'm not going to go through it all, but it's there for you as well. What the adolescent and the child observes, you have to give more credit than what you might already be giving them. Kids see everything. They notice everything. And while they may not understand it, it doesn't mean that it's not something that's triggered and kind of processed and remembered by them. So they will observe things like, and forgive me, this slide looks dated right now by just saying mom, because it has very much also been dad or grandma or uncle. But let's just use mom as the example. Mom doesn't eat or doesn't eat with them. Mom doesn't eat what we are having. So the whole family has something, mom has something different. Mom is regularly talking about food. Oh, I shouldn't have this. Or, oh, you guys better enjoy it while you're young, or about weight or about body. And they mimic everything. So this includes eating patterns and the language and the way that they talk about themselves and their body. Some different things that you can do to kind of identify if there might be an issue is to ask if kids eat differently with their friends or at school or at daycare than they might eat at home. I'll never forget that. And this is Elliot, again, a little bit older. This was his first chocolate, and it was an Oreo, if I remember correctly. And he is making a mess. And he was my tough eater. He struggled with feeding from the moment he was born. So my second kid came along and was a lot easier. So, are they eating differently? When I used to send him to daycare, he was not my big eater, and I'd pick up and she'd be like, he had 3 hot dogs for lunch today. And I'm like, I'm sorry, what? Like, why? Like, what? 3 hot dogs. And it was part of the environment, I think, too. He might snack at my home a little bit more, but 3 hot dogs is just extreme. It's like, you having a hot dog eating contest in the middle afternoon here? But regularly he would take down food, and she would make these big meals like meat and potatoes and stuff like that every once in a while. It was a very nice in-home daycare, and she made everything homemade. I was very lucky. However, he wouldn't eat like that for me. He wouldn't even try some of those foods. So it was good. I encouraged that behavior. Are they eating instinctively? Are they constantly, if you know that you're going to get a treat at the end of finishing your meal, are you going to enjoy the meal? Or are you just going to scarf the meal down and then expect the treat? So you want to make sure that they have a connection to when they're hungry and when they're full. You obviously want to limit distractions while they're at the table. And it's important to recognize those different rules, because the more you try to control, the more difficult it becomes and the more the child is going to resist, especially if it's something really unenjoyable for them. So it's important to kind of make some different concessions and to work together to figure out how this is going to be, obviously within reason and within guidelines. There is a strong comorbidity that can occur with eating disorders and some other mental health or intellectual and developmental disabilities. One of them being autism spectrum disorder. There's a lot of information out there related to some rough guidelines around diet connected to reducing different behaviors associated with autism. This may include gluten-free, casein-free, dairy-free in general. The keto, they're looking at the really high fat as associated with epilepsy. Regardless, you have to be really careful because some of these conditions alone can have their own food issues. Autism can present with some different textural issues, some different color issues, timing issues. There's lots of different patterns that can be associated to food related to not an eating disorder, but the motivations and the thinking process for that individual. Substance abuse can also be a comorbidity, starting to use at a very young age. Oppositional defiant disorder and conduct disorders, these are, we sometimes want to say my kids have it, but they don't. This is a very, very strong resistance to any type of authority or any type of direction. ADHD can be another one. Tourette syndrome can be another one where you acquire food behaviors associated with it. And then obviously similarly to adults, anxiety and depression, which can be identified at very young ages. It just doesn't always present itself in the same way that it does with adults. A study in 2000 with Brayman and Bosch found that 67% of eating disorder male had anxiety and depression, and about 50% had had an actual suicide attempt. And then in that same study, in Carlat in 1997. So we were doing some things 20 years ago, but still, Carlat in 1997 found that 61% of bulimic males, those with purging type behaviors, actually had correlating substance abuse. So the correlations can be pretty high, which is similarly presented with adults. I do want to take a minute to touch on RFED. So RFED is avoidant restrictive food intake disorder. It is a feeding disturbance with a lack of interest in eating or food. And sometimes it can be based on sensory characteristics of food or consequences related to consuming those foods. And it's manifested along with some sort of failure to meet appropriate nutritional or energy or growth guidelines for that particular person. So this could mean significant weight loss or the presentation of a deficiency. There could eventually lead to some sort of dependence on enteral feedings or some sort of oral nutritional supplements. And then there can also be a correlating marked interference with psychosocial functioning and overall ability to interact with different populations. So you're going to be reading an article that takes a look at how RFED presents differently than traditional eating disorder diagnoses when evaluating weight motivations and body disturbances. In other words, those that present with true RFED are less concerned with body and weight than those that present with a diagnosed eating disorder. And a lot of times, because RFED is newer to our scope of practice, in all of the different professions, it can be hard to differentiate RFED behaviors and motivations from eating disorder stuff. So that can be really tricky, but one of those ways to do it is looking at that body and weight disturbance. What else do I want to talk about here? You can read through some of these different things. I do want to identify that RFED can be diagnosed in adults, but oftentimes is associated specifically to children and adolescents and young adults. Another thing that happens in RFED is bringing in an occupational therapist or a speech pathologist, anything that's related to the actual functioning, the swallowing, and that kind of occupational therapy around different behaviors can be really important to do. But again, just like what we're all struggling with, which is learning RFED and understanding it from our own professional perspective, we find that the same thing is happening with these different practitioners, is they're not getting a ton of training and understanding on it. So it's a specialty where you have to kind of go in and find out what you're going to be doing. But that can be a really helpful component with our Fed. I want to touch briefly on the LGBTQ populations, and there is an increased evaluation of the trans and the gay communities as it relates to prevalence of eating disorder behaviors. There can be, especially if a child or an adolescent or young adult is starting to identify differently, whether it's related to gender or it's related to sexual orientation, there can be strong fear of rejection with how friends and family and people will respond. There can be internalized negative messages or beliefs regarding how they are perceiving what they want to do and how to express that. Any kind of PTSD or experiences of violence or any kind of negative reactions associated with, you know, how you present yourself or what your sexual orientation can be is obviously very traumatic and increases vulnerability. Discrimination events can increase vulnerability. Being a victim of bullying in general, in particular associated to gender or sexual identity, orientation, sorry. And then just the overall internal dialogue, that internal conflict between what society is saying that you are, you should be, or, you know, that kind of thing, and what you feel and what you know inside can be a huge trigger. So it's just important to make sure that all of these things are being talked about and addressed when appropriate, because they are profoundly challenging for the individual, and that can lead to a lot of susceptibility. If you think about what you're going through when you're trying to make yourself sexually attractive to a new population that you haven't been exposed to before, and you're new to that, that would put a lot of pressure on how you look and your appearance, and could lead to more extreme behaviors. On the other side of that, if you're looking at your gender identity and doing some sort of shift or change, traditional males and females in how our society views it are very different. And so that can again lead to some different extreme type behaviors. So all of these factors need to be considered when working with someone, and additional care and training should be done to understand how best to support these populations. So with that said, let's transition a little bit and talk about males with eating disorders. Currently, the percentage is 10% of diagnosed eating disorders, all total, are male. I think that it's much higher than that. I think that it's 25%. And in fact, I think that we're getting closer and closer to a point where a number of men struggle just as much as the strong number of women who struggle with body dissatisfaction and the desire to change and utilizing behaviors as a form of control. The thing that happened that I think was a big component to how we missed males and eating disorders for so many decades, excuse me, is that boys and men are up to 3 times more likely to be trying to gain weight. And that just didn't resonate with our understanding of eating disorders early on. Weight loss is secondary to being in control of how their physique looks with compared to females. So the number on the scale is less important than what the body looks like. Being overweight as a child was very common in those who eventually acquired eating disorder behaviors moving into their young adulthood. So a desire to go from that chubby or fat little kid into somebody who is not that person, and is viewed by society as being more manly and more masculine, and more present, and again, more in control. And so that can be a strong motivator as they move into a different body and in different stages of that young adulthood. One study found that nearly 16% of boys thought they were overweight when actually only 5% were. So that concept of diet culture and the need to change and how we view our body as many as 15 years ago was already starting to impact young boys. And then they've also found that there's an increased risk for those boys that have some sort of a delayed maturation. It can increase the risk of eating disorders because it's linked to poor body image. They feel too small, or they feel different than their peers. They feel decreased acceptance. They might have greater issues with their mother or father. It can also increase depressive symptoms within their struggle around those changes. So all of these factors can play in. And you'll notice, and I've kept the information here a little bit more dated because this is when we were starting to learn a lot more about males and eating disorders. And so we do kind of have a much better sense of what that looks like now. There are a lot of confusing messages. I know this is an older reference, Team Jacob and Team Edward, but if you really think about it, it's kind of the two ways that we allow young males to present themselves in society. So you're either this hard body, independent, strong type, or you're sensitive and emotional, and you're a little bit like thinner, but you're tall and you're still strong. And then again, you have to be available a little bit, but not too much. This kind of like supernatural component to how we expect men to be present in our culture. And then there's a couple of different discussions, and there is a book as well regarding the boy code, which is this ability to present a masculine upfront persona. And so it's really important that we get away from that. We allow guys to talk about what's going on with them. We allow boys to talk about their emotions. We allow them to express themselves, which can be hard to do in general, and even more difficult if you feel as though it's not appropriate or it's not acceptable. The other thing that's really interesting, I worked in eating disorders for about 3 years, and it was only females. It was Rosewood Women's Center for Eating Disorder. We had women in there somewhere. And I remember when I got the message in 3 months we're taking on men. And I was like, I'm sorry, what? What do I do? And it would seem like it wouldn't matter because it's just a person. But it did, because there was a sense of a real feminization to how treatment was done, how discussions were had, how we talked about emotions and feelings. And I just knew instinctively, having had a number of guy friends and knowing guys my whole life, that would be a weird environment. Like I was like, this environment's going to have to change. And it did, but it changed a lot for the better too. And the dynamics of males and females together having this discussion is actually really powerful. So one of the things that happened is the men struggled to connect in the way, like just as I had anticipated. They struggled to connect with a lot of the different risks associated with eating disorder behaviors. Women tend to see side effects a lot faster than men do when engaging in different behaviors. So men don't connect as closely to some of the secondary consequences. They don't lose their period. They don't have a fear of not looking feminine enough. So you lose enough weight and you lose your breast tissue and you're not curvy and you're not attractive. And eventually you could get to a point where your hair starts falling out. That's unattractive. Your nails start breaking. Your skin looks terrible. There's a lot of things that can happen in a female eating disorder that don't necessarily present as negatively for men. And then down the road, which a huge amount of studies are going on right now, looking at infertility and long-term eating disorder presentation, but it could reduce your risk of having a child. So those types of things become really key nutritional motivators for a lot of people that are struggling with their eating disorder. The other thing that happens with men is they become hypermetabolic very quickly. So we see hypermetabolisms in females as well, but men are already a little bit more hypermetabolic, having higher lean body masses in general. So they need a lot of calories. And if they are deficient, the amount of food that some men have to eat in order to get their body back to where it needs to be is pretty insane. Skinny can mean different things too. So the language overall and how you talk about eating disorders with a male and a female, for a long time, I had to be very aware of my language. Now, because it's a little bit more mainstream, I don't know if it's as much of an issue, but you have to recognize that if you've got someone coming in and they've got a lot of eating disorder behaviors that they've normalized through diet culture messages, it's going to be hard for them to understand how emotions are connected to food. So there's certain things that start to happen, like the use of language like skinny or restricting or purging. It's instead like throwing up. Do you feel thin? Do you feel less muscular? Like, do you feel strong? Also, men tend to have much less food cravings than females do. So if a male picks up on a specific, let's say, diet or a means of eating or restrictive eating pattern, in a lot of instances, men can take on small dietary changes, be committed to them because they have some of those less food cravings that kind of trigger their need for some of those foods that might fall outside of the parameters of that diet, and actually see weight changes very quickly. I remember when Atkins first came out, and it was one of the first diets that really appealed to men. I can eat all the bacon and all the cheese I want, and I don't even have to eat that many vegetables, and I get to lose weight. Like, sign me up, right? So women and men would go on the Atkins diet together, and the men would drop weight super quickly, and the woman would be down a few pounds and feeling lightheaded and dizzy, mostly because they were carb restricting. Not saying that women didn't also have success on Atkins, but it was funny when they would do it together. So we have to recognize that. Also, boys do approach food a little bit differently socially. They're a little bit more casual about food. There isn't a fear of eating too much food in a lot of ways, especially for young males. Making contests around food and laughing around food and being silly around food is pretty common. Women and girls, we don't tend to do it that way. I will caveat that to say, more men are now talking about diets and the diets that they're on and the regimens that they're doing than ever before. So I don't know if that's necessarily changing how young men are viewing food, but I would imagine it is. I recently actually had a New York City firefighter who was there for 9/11, come in for treatment, struggling with binge eating disorder, a strong history of kind of extreme eating, and just a really solid individual. He was just such a nice, good person with a huge passion for his city, his family, the fire department. And he is also in a strong place of depression right now because the firehouse dynamics have changed. Now everybody, like a firehouse, when you would do a 24-hour shift, is really universally known as being a place where they cook food together. It's a family. You eat all your meals. You play games. You hang out. You socialize. It's really this tight-knit crew. Well, now everybody's on their own diet, so you can't cook for the entire firehouse because this person's not eating this person's not eating this. Everyone brings their own food, so nobody eats together at the table, in addition to the fact that we now have technology and we have headphones. And so people just isolate in the firehouse doing their own thing all day. And that shift in that one generation to what the new guys are doing has really been hard for him. And he only has a few years before he retires. But it was heartbreaking to hear about that, because how do you go into a fire and how do you have that connection with everybody if you don't know each other really well and you're not spending that time? So a little tangent, but I think it's relevant. Bone health is still really important. Low testosterone can be an issue. And I already mentioned less food cravings, but apparently I wanted to keep putting that in there. These are some just differences in how I would go about talking through questions that might occur between a female and a male person. And asking, again, using a language that they connect with. But with a female, I might be able to go a little bit deeper, be a little bit more specific. And with a male, I might need to look at some different things too, such as supplements, protein powders, shakes, all of that kind of stuff. How much of that is being consumed? And that utilization of those supplementation, those GNCs, those muscle builders, all of those things is a strong component to the eating disorder world for males in general. So the connection begins here. Every time someone comes in, I am really trying to get them to slowly but surely attach some of their actions, not only to just, well, I thought that's what somebody told me one time. Like, I want to see if they can go a little bit deeper than that. And I am not trying to say men aren't deep. What I am trying to say is when they come into an environment that is unfamiliar and outside of what they might have been used to doing, in their family, in their social circles, that you just need to give it a little bit more time. My awesome guy from the fire department, holy cow, it took weeks for us to get him to identify an emotion. And he was just always a happy person, but we knew that wasn't the case. So just getting deep down in there with him. So you really want to make sure, again, that it's the same thought processes for a lot of components of working with males and females, but the motivations, the understandings, and the drive for their eating disorder can present itself very differently. Clinical features and body image. Again, over-exercising is more likely a form of compensating than purging behaviors. They're less likely to induce vomiting, males that is, than females. Not to say that they don't. It's more about some sort of lean or muscular appearance. It's not necessarily about gaining weight so much as it is gaining muscle. It's not so much about losing weight as it is about appearing thin or lean. So it is motivated and discussed slightly differently a lot of times. Again, that preoccupation and over-evaluation of body image is present for males, but that's not to say that females don't do the same thing. It's just females will do a little bit more. The men are going to be a little more associated with physical appearance. And again, a little bit less self-aware around some of the clinical issues and some of the eating disorder symptoms or behaviors that might be going on. So factors that might present for somebody who is a restricting male would include prevent further ridicule for being overweight, enhance a certain ability to perform in a sport or in a particular area of interest. They might also be motivated if they had a father who got sick or died very young related to what might be a chronic disease or something they think is preventable. So that would cause them to immediately take on this like component of health, which might go to an extreme. And then in the homosexual community, there is a sense of a typing of males within the homosexual community. And those types have a very specific look and physique appearance associated with that. And that is very much a part of that appearance that I want to say like a sharpness, cleanliness doesn't seem right, but that first impression and that physicality does play a strong role in the gay male community. And that needs to be considered if you are working with a gay male. So let's dive in a little bit on athletes. So I'm going to try and get through athletes and bariatrics here pretty quickly. Athlete concerns. There's a ton of them. They can be carb restrictive when in fact they should be eating more. They can be calorie restrictive, which can do all those things. They can lose lean body mass through being restrictive. Do they have some sort of chronic injury? Are they reporting the injury? Is the injury not healing? Are they being honest about what's going on? Obviously, the presentation of amenorrhea, which for decades we have just written off as a part of being an elite athlete, and now we know that should not be the case. Bradycardia can present as a very, very low resting heart rate, which can be common in very high performing endurance athletes, but it can also be deadly. And then overall, depending on the sport and depending on how successful and competitive they are, body image awareness is just going to be a constant factor. Aside from like professional or true competitive athletes, whether it's through high school all the way up into the professional arena, we also have a growing population of recreational athletes. So people doing triathlons, marathons, Ironmans, mud runs, spud runs, zombie runs, color runs. I don't know. There's like a million of them now. We go from well-trained to amateur participants. I'll never forget one of my good guy friends who I didn't even know exercised at all. And I'd known him forever, was like, I'm going to run a marathon in 2 months. And I was like, what? How are you going to do that? And he did it. And he never had run before. So that's great for him, but there's a concern with that. And that the body may be able to manage it and handle it, but it can lead to some significant issues. So we have millions of amateur and middle-aged athletes. This is seen to be as 35 and older around the world. And there remain to be concerns about cardiovascular strain for people that go out and just sign up for some of these kind of endurance runs and they make it through the race, but in the meantime have done significant damage, and in some instances actually end up hospitalized as a result of it. CrossFit has really kind of put itself center stage. It might be dying down a little bit more here, but for about a decade, CrossFit has been a huge component. They have competitions worldwide now, and there is a continued evaluation within CrossFit of the higher incidence of injuries, in particular reference to rhabdomyolysis, which is a straining of the muscles to an extreme degree, essentially. And the thing that I struggle with regarding CrossFit too is it's highly associated with different popular diets that are out there. So for somebody who's coming in and wants to accomplish something, I think that there's a ton of benefit. I know a lot of people that have a great community of friends at their CrossFit gym, but making sure that everyone is doing things appropriate to their level and not taking it on too much. And that women's CrossFit creed is just intense. So I thought I'd share that with you. Some different risk factors and signs that somebody might be struggling with an eating disorder within their sport, which it's important to recognize eating disorder within all sports. Prevalence is much higher than you would ever imagine. But if someone is doing a fasting or a cleanse as an athlete, red flag. Overall, the dieting, the restriction of kcals, restricting certain types of foods. Obviously, you're a bodybuilder and you go through all of the cutting and that kind of stuff. It is what it's got to be. But this is kind of looking at bigger picture. Any kind of purging, excessive exercise, training outside of what the training regime is, the overuse of food substitutes. Obviously, that would include like the supplements, the drinks, the shakes, that kind of stuff. Obviously, perfectionism, which is a necessary evil in some way. Isolation, separating yourself from your team, from your coaches, any kind of external pressure to lose weight. Serena Williams, after she had her little girl, did a documentary on HBO, and I am a huge tennis fan and a big Serena fan, and it was really hard to watch how her and her coach had discussions around her body and her weight. I mean, she's already accomplished so much as an athlete in general and done it in a body that tennis would have never thought would have ended up on its court. And I've loved her so much more for showing everyone that. But she's not the first athlete to do something kind of outside of the scope of body types. And we need to see more of that. Frequent weight cycling, like huge weight fluctuations on and off season or that type of stuff. Early start of sport-specific training, not allowing yourself that time off, overtraining, injuries. And then overall, what is the behavior of the coaches and the influence of the coaches? So it used to be the female athlete triad, which we took a look at, and it looked at 3 components related to female athletes who would struggle with an eating disorder. It took a look at amenorrhea, took a look at bone health, and it took a look at overall energy intake as related to deficient to energy expenditure. That's a great start, but it doesn't include men, and it's pretty limiting. So what ended up happening as a result of that is the relative energy deficiency in sport was created by the International Olympic Committee. And it is terrific. There's a revision that you're reading this week. And what it essentially does is takes a look at 2 components that are physical. Inadequate energy intake related to disordered eating or eating disorder behaviors, and a lack of knowledge about how to properly fuel their body. And then impaired physiological functioning, which can be related to just about any of the different systems in the bodies not working right. The other side, this is just the physical. They have an entire separate section that is related to the mental health and the mental well-being of the athlete, which is just as important, right? Especially at that competitive level. So with that last chart and staying in the physical realm, they created these 2 different images, taking a look at all of the components associated with being involved in Red S and getting all of those things in alignment for an athlete to be successful. And once that's kind of evaluated and assessed, then you can give them essentially a red light, a yellow light, or a green light related to training. The fact that the International Olympic Committee actually created criteria that would allow them to be in a red light, high risk scenario with no competition and no training with the use of a written contract means they don't want to kill their athletes. And that is reassuring because athletes do kill themselves to be the best. So this is a really nice, easy, functional, you're going to read it, terrific way to evaluate athletes in the whole perspective. That is what they're trying to accomplish and how they're doing that, to make sure that we take care of them for the long term. Muscle dysmorphia is a subset of body dysmorphic disorder, which is included in the DSM-5 and is associated with this bodybuilders, bigorexia, subset of eating disorders. It is body focused and it is body distorted. The desire is for strong muscularity. They spend tons of hours in the gym. They have meticulous diets and they utilize lots of the different supplement powders. And in some instances, maybe even anabolic steroids. Some will even use plastic surgery to create a muscular look if they're unable to do it. And they are very self-conscious about their body and yet avoid social situations. So the persona that happens in the public setting is not the persona that they have when they're in their own setting. I just have these two images here because the one on the left is Arnold Schwarzenegger as Mr. Universe, and the one on the right is Mr. Universe, I don't even know how long ago, a few years ago. And it's like, Arnold wasn't enough. We had to go to the guy on the right, you know, like we're always taking our bodies, our abilities to these extremes. This is just a little bit of a summary of the research related to the supplements that are out there and how they're touted and promoted. And the bottom line is nothing has really been shown to be effective, just as much as they want to keep putting it out there that it is. It hasn't been, it isn't, and I just don't think that they're going to be able to make anything that's better than food at this point. So creatine is one of the big ones that's out there. In 1,700 research articles, mainly they found that there is a benefit to enhance sprint work specific to swimming, running, and cycling. There's a little bit of research correlated to caffeine as well, but again, it's minuscule. It's important to also recognize the FDA does not regulate these supplement products. So what's in them or what they do, we're not always going to be 100% sure. And still to this day, the best recovery beverage that a person could have after working out is low-fat chocolate milk with a 4-to-1 carb to protein ratio. So that tastes better than any of those other supplement drinks, right? Just saying. Protecting the athletes, the National Athletic Trainers Association and the NCAA in the early 2000s went about reevaluating their standards around posting times, posting weights, posting all of that kind of stuff. What it did was essentially fuel eating disorder behaviors. And once eating disorder starts on a teen, it has a tendency to spread like wildfire. So recognizing the different struggles of the cultures and the issues associated with the competitiveness, they've done a few different things to make some changes in how they view that competitive nature within the athletes. So nutrition interventions include regulating their intake, 3 meals, 3 snacks, a balance of nutrients, a focus on nutrients and less on grams and calories. For some, it's necessary to remove them from physical activity, which we mentioned with the red S. Again, focus on performance, measurable data that is sport specific rather than body related information. Always take genetics and family history into account, create individualized plans, encourage normalization of sweets, and then make sure that they're getting the right information, because your teammate or another successful athlete or a rando on the street or looking it up on Instagram is not going to tell you what you need for your body. These are just some general guidelines for athlete nutrition considerations that I'm just offering up for your consideration. And so this was a really cool study done in 2014 that looked at the different factors that help recovery and kind of the ranking of those in popularity. So you can see here that there's a lot of things that can be helpful in recovery. I will tell you too, I have worked with a number of athletes who've ended up deciding they were done with the sport, not at all in my urging, but just recognizing they had worn it out too long and they just didn't want that to be the focus anymore. And I've had others get so much better and do so well in their sport. All right, let's finish by just touching on bariatrics. Bariatric criteria involves a BMI above 40 usually qualifies you, or a BMI of 35 to 39.9 with a weight-related condition such as, and I say weight-related, this is This is bariatric criteria, not me. High blood pressure, type 2 diabetes, sleep apnea, GERD, those types of things. Most insurance plans require some sort of supervised weight loss or weight monitoring or sessions with the RD in order to see what your level of commitment is or what you can do on your own before they pay for this surgery. But it's a double-edged sword. If you don't lose any weight, they think you're not committed. You lose too much weight and then you don't need the surgery. So it really puts clients in kind of this catch-22. Centers of Excellence for Bariatric Surgery will offer medical, psychiatric, dietary, nursing, and educational classes as a part of their screening process. But that is not the case at all treatment centers. And it also doesn't mean that even if you're a center of excellence, that somebody won't come in and be dishonest, right? So it's really, really key that things are screened for. And one of the biggest issues in bariatrics right now that I have is they don't have as effective screening tools as they could for working with catching people with disordered eating behaviors early. These are those additional medical indicators for surgery in that 35 to 40 BMI range. So let's look at the 3 procedures we're going to talk about today. We are not going to talk about the duodenal switch, which is the revision of the gastric bypass, Roux-en-Y, because it rarely happens. I've seen it 3 times and it's a nightmare. So we're going to talk about the 3 most common, with laparoscopic adjustable band being the least common right now and actually moving out as a procedure that is seen as viable. About 4 years ago, they had some 10 years of studies that they were able to look at, and they just really found that the weight loss wasn't sustained and the weight loss wasn't very great. What happens is it is invasive in that it's not changing the GI makeup. So a band is put around the top of the stomach here. I'll use my little mouse. So the band is put around the top of the stomach here. This port is inside the body, and this sits right outside. If I veer down, like your stomach right here, this would be inside right here. You'd be able to kind of poke at it and touch it. And so what happens is they can inject saline into this access port just through a needle, and then it fills up this band, and it changes this diameter of how big that pouch is and how much food can get through. And you play with it until you find what they call is the sweet spot. So the idea is you're not having any kind of like things coming back up. You can eat small portions, the weight comes off, that kind of thing. But again, long-term success with this has not seemed to be the case. So what they end up doing is offering a revision, and that is what the industry likes to do, because if we can't get you to the weight you desire, we've got a surgery that probably can do it. So one of the most common and the newer types of bariatric surgeries is the vertical sleeve gastrectomy. And this does restrict, it pulls out about 80% of your stomach and restricts the amount of food the stomach can hold. They find that you have rapid and significant weight loss with comparison to the gold standard, which is the Roux-en-Y. Weight loss data is looking at greater than 50% of excess body weight, not total body weight, for 3 to 5+ years, which is pretty comparable to the data associated with the gastric bypass. It doesn't require the insertion of foreign objects. It doesn't have any rerouting of the food, and all of that helps with the overall adjustments and long-term health of that GI system. It's a relatively short hospital stay. It is all done laparoscopically, and usually you're there for about 2 days. It does also demonstrate results in favorable changes to gut hormones, including reduction in overall hunger, reduction in that appetite component, with improvements in satiety with small amounts of food. Okay, so 80% of the stomach is taken off, taken out of your body. Here we have the Roux-en-Y. So this is the gold standard in bariatric surgeries and weight loss. Weight loss is seen to be moderately sustained for greater than 5 years. And the key components to this is almost immediate reduction in type 2 diabetes presentation, hypertension, and then the sleep apnea and the GERD. So even without a significant amount of weight loss, just the procedure alone actually starts to decrease those particular components. It is technically a more complex surgery, and it can lead to long-term vitamin and mineral deficiencies due to some of the rerouting, in particular when looking at B12, iron, calcium, and folate. It usually does require a little bit of a longer hospital stay than the gastric sleeve, and there are long-term permanent dietary interventions that need to be considered. So this is called the Roux-en-Y, because if you were to take this part of the stomach and just move it over here, you would see that it would create a Y where it connects here. So what happens? That pouch of the top of the stomach is cut off and the stomach is moved over but not removed. I'm looking at another screen that I have here, so sorry for the side of my face. And then what they end up doing is they take the lower part of the duodenum and they attach it directly to that new stomach pouch, okay? But they don't want to lose all of the digestive components that are associated and very critical for this top part of the duodenum. So they reattach it to the lower part of the small intestine right here, well, to the lower part of the upper small intestine right here. And then you still get all of those digestive juices, but they're going to hit later in the process. I hope that's clear, okay? So that is the Roux-en-Y gastric sleeve. There are definitely more complications, and depending on how in tune the person is with following the dietary recommendations, there can be some long-term discomforts with this. But I also know a lot of people that did not have food issues that went in very committed to what was required of them for these procedures that had a lot of success long-term. So what are those dietary interventions, you ask? No caffeine, no caffeinated or carbonated beverages, no sugar-containing beverages, no alcohol, no tobacco, and portion sizes are very, very small. The caffeine, the carbonated beverages, and the sugary beverages are related initially to the stimulation of the GI tract, the surgical component, especially with the carbonation of all of those sutures. And then the sugary beverages can result in, I don't know why I'm doing this. This is your stomach. Okay, sorry. The sugary beverages can relate to dumping syndrome. So we could do a lot on this particular topic, but if you're not screened beforehand, you will not follow these recommendations, or you'll struggle to. If you had other compensating behaviors you can't engage in anymore, it's not uncommon to turn to alcohol. The reduction of the stomach size actually plays a role in increasing the absorption rate of alcohol. So small amounts of alcohol can lead to significant amounts of intoxication. And there's a lot of research that has come out over the last couple of decades looking at the number of incidents of alcoholism, secondary post-bariatric procedures. And it's not that they're drinking because they had the surgery. I'm not blaming it specifically on the surgery, but it's like, I don't like my life right now, I'm going to move, well, all of your problems just move with you. It's not changing the scenario. So if there's bigger issues that aren't being addressed, you're just creating a new subset of problems. These are the components associated with the really critical dietary components to helping support someone in bariatrics. I mentioned dumping syndrome earlier. This is where the food moves too quickly into the small intestine, causing nausea, diarrhea, a feeling of fullness. It can lead to that immediate, that feeling when you're done, where you have sweating and cramping and flushing and a rapid heartbeat. And so there's no time to get to a bathroom. Like, you're going to need to be at a bathroom pretty immediately. So certain things such as the carbohydrates, the desserts, the high sugar containing foods, including fruits, can cause dumping. Overly fibrous, overly dry foods are very difficult to digest. You want to take small bites. You want to chew completely. You want to eat slowly. You need high protein along with key supplementation, fluids before and after meal and snack times, not during, and then specific supplementations. All right, we're finishing right here. There are two current in the works FDA approved bariatric support systems that are being looked at. The first is this nanoblock procedure. This is a gastric artery embolization, where they take these little bead particles. Oh, annoying, these little bead particles right here, and they inject those in order to reduce the production of ghrelin, which is our hunger hormone. And so it's supposed to reduce your triggers for hunger and have you lose weight. The other one, Oblon, is just one example. There are actually a couple of different companies creating these swallow balloons. So they use a scope through the nose, and then they go down and they put these deflated balloons in the stomach. Usually 1 to 3 are placed, and then they go in and they fill them with gas. You keep them in from anywhere from 12 weeks to 6 months, and then they're removed endoscopically as well. And the idea is having them in there displaces the food, creates a feeling of fullness. You're educated on diet and exercise during that time, and all of that leads to a greater reduction in weight. It is really important to recognize that the FDA is investigating 5 deaths, 4 of them associated with Obera, which is a different company. 5 deaths that have occurred since 2016, 3 of which happened 1 to 3 days after placement of these balloons. The side effects currently, aside from the potential of death, are nausea and stomach pain for the most common side effects. So just so you have a little heads up on what's going on in the world. What are they doing these for? The desire is to lose 60 to 80% of excess body weight within 2 years. 18 months to 2 years is where the decline happens, and it's less likely for weight loss to continue. You're at a 2.2 times, so that's 220 times higher risk, 220%. I'm just trying to put it in a context. 2.2 times higher risk of not losing the weight when you don't change those eating habits even before the procedure. Estimated 16 to 35% who are seeking bariatric present with binge eating behaviors that are unassessed. 60% present with grazing, binging, or loss of control with eating, all identified as post-op in one study. And almost 20% of bariatric candidates did fail to be cleared in one particular evaluation study when overeating was identified for them. The trick with bariatrics and eating disorders is there are some pretty strong eating disorder-like behaviors that or actions that can result after you've had a bariatric procedure. So I can't tell somebody that they're causing themselves to purge, or if I don't know that it's not truly involuntary vomiting secondary to it. The concept of food being stuck, like if they're eating things regularly and it doesn't even make sense, like the foods don't correlate as to what gets stuck and what doesn't, I can't dispute that. Somebody who comes in and says, well, I'm never going to have another dessert again because I had a bariatric procedure. Like, okay, I get it. I get, but is that reasonable? Is that realistic? Why do we even need to talk about it? There's just, you have to kind of decide in these moments where they tell you things, is this motivated by the procedure and your desire to care for yourself, or is this motivated by the procedure as an excuse for the eating disorder? And a lot of times that can be really hard to wean out. They do and currently are performing adolescent bariatric procedures. I can't go into it because I do really have a hard time with this one. This is from the website at Nationwide Children's Hospital in Ohio, but here in Phoenix, at Phoenix Children's, they're doing them as well. So I just want you to know that it is a thing. And this is a case study as a bariatric client. It's a little bit more of an extreme situation. A 50-year-old female, unemployed on disability, admitted to our inpatient unit at 90 pounds, a BMI of 17, lost 40 pounds in the last 6 months. But if this was around 2015, she had had the gastric bypass in 2002, weighing 399 pounds. And I found that out after she'd been in treatment for 3 days. And I remember thinking, it's not even possible. Her entire body, skin and everything was so tiny. I don't have her height on there, but you could back calculate her height, but she was short. And I just couldn't believe it. She did have opioid abuse, benzodependence, and her parents were both drug and alcohol addicts. She had previously been at treatment with us at Rosewood about 5 years ago, but it was very short-lived and she didn't complete treatment. Bottom line, she was binge eating on about $200 of food a day, purging everything, including just saliva. She was restricting, obviously stealing food because she couldn't afford that much. She would drink almost no water, only caffeine. Lots of medical issues, tons of missing teeth, and actually started sneaking into our kitchen, which everything is keypad locks. So you had to have a key and a code to get into any of our doors. And she would hang out around a corner where you couldn't see her. And as soon as the door would open, she'd race in. We had a cart with condiments, and she would start shoving everything into her mouth, in particular sugar packets and things like that. And we were feeding her. But the idea here is, and there's a lot going on, obviously, and I'm not saying that the gastric bypass triggered it, but just because you've had a bariatric procedure, over time the body heals, and what the body can do when the motivation is strong enough is pretty amazing. So she did eventually get to a point where she was consuming food. She wasn't sneaking into our kitchen, but we had her on no raw veggies. We had her on very high protein. We did really get her hydrated again. And about 30 days in, she discharged at a pretty stable place, but absolutely not meant like physically stable, but not mentally stable. And we did not recommend her discharge. Okay, I'm at an hour and 5 minutes. Sorry, guys. I don't know how to do it faster. Thank you for joining me. Let me know if you have any questions.